Good afternoon, folks. Today's topic A, we are discussing CMS's new rule for requires Mini Medicaid expansions. Older adults to meet an 80-hour a month work or community engagement test. Okay. So we'll dig into that for A. So please join me for the presentation I made for you. Here we go. Short answer: the new CMS rule requires Mini Medicaid expansion adults to meet an 80-hour a month work or community engagement test starting January 1, 2027. And it tightens the medically frail exemption. 0 people must repeatedly prove that their illness truly prevents them from meeting the requirement. This shift could cause some seriously ill patients to lose coverage if documentation isn't accepted. What the rule actually does and why it matters. The Centers for Medicare Medicaid Services, CMS, issued an interim final rule on June 1st, 2026, implementing nationwide. Work requirements for most Medicaid expansion adults ages 19 to 64. States must verify that enrollees complete an 80-hour per month of work, job training, education, caregiving, or community service. The rule takes effect July 31st, 2026, and states are expected to begin enforcement January 1, 2027, unless they receive limited implementation delays. This is the first time the federal government has required work verification for Medicaid at a national scale. It represents a major administrative shift for states and a potentially life-altering one for medically complex patients. What changed for people who are sick? The most consequential change is the narrowing of the medically frail exemption, which historically allowed people with serious health conditions to bypass work requirements. Under the new rule, a diagnosis alone is not enough. Patients must show that their condition significantly impairs their ability to meet the 80-hour requirement. Fatigue, cognitive impairment, treatment, treatment side effects or mobility limitations must be documented in, in functional terms. Self alter self attestation is temporary. Patients may initially attest that they are medically frail, but beginning in 2028, many will need to provide formal documentation every 6 months to maintain the exemption. States must verify. States are required to build systems to access medical frailty, review documentation, and track compliance, all under tight timelines. Experts warn this will create bottlenecks and errors for patients undergoing chemotherapy, living with chronic fatigue, or managing cognitive effects of treatment, like the North Carolina cancer survivor, heightened highlighted in the AP reporting. The burden of repeatedly proving illness can be overwhelming. Why advocates and analysts are alarmed. Health policy experts warn that the rule will produce more paperwork for the sickest Medicaid patients and increase the risk of unnecessary coverage loss. Not because people are able to work, but because they cannot navigate the documentation process. Key concerns include administrative conundrum. People who are legitimately too sick to work may lose coverage simply because they miss a deadline or cannot obtain timely documentation. Functional impairment standard. Many serious conditions fluctuate, making it hard to prove impairment on a schedule. State capacity. States already strained by Medicaid unwinding must now build new verification systems quickly. Treatment disruption. Losing Medicaid, even briefly, can interrupt chemotherapy, dialysis, mental health care, or medication access with life threatening consequences. Practical steps. If you or someone you care for may be affected, these steps can reduce the risk of losing coverage once the rule takes effect. Start building a document Start building a documentation file now. Request a clinician letter that describes your diagnosis, specific functional limitations. For example, e.g., cannot sustain activity for more than 1 to 2 hours, severe treatment related fatigue, cognitive impairment affecting memory and concentration. How these limitations prevent meeting an 80-hour monthly requirement. Keep copies of treatment schedules, infusion logs, imaging reports, and medication lists. Submit self attestation early. When your state opens its portal, file the medically frail attestation immediately to preserve coverage while gathering documentation. Check your state's rules. Each state will publish its own list of qualifying conditions and documentation requirements. Call your state Medicaid helpline or check the state's Medicaid website. Seek legal or advocacy supports. Disability rights groups, cancer patient organizations, and legal aid offices can help with appeals if an exemption is denied. Timeline to watch: June 1st, 2026. CMS issues interim final rule. July 31st, 2026. Rule becomes effective January 2027. Work requirements begin in most states. (2028) more stringent documentation cycles for medically frail exemptions began. Below is a full published Senate testimony on the new CMS Medicaid work requirement framework, written in your established voice as a Pennsylvania health system executive. It is structured for delivery before the Pennsylvania Senate Health and Human Services Committee and emphasizes operational realities, medically frail protections, and statewide system impacts. Guided links are embedded on key concepts so you can pivot to deeper detail as needed. Okay, subject: federal Medicaid work requirements and their implications for medically frail adults, state capacity, and health system operations. Okay, here we go, guys. Um, my name is Felicia, and I serve as a health as a health system executive in northwestern Pennsylvania. My responsibilities span acute care, behavioral health, primary care, and long term care transitions across a largely rural region where Medicaid is the backbone of coverage for working age adults. I am here because the new federal framework for Medicaid work requirements is not a routine regulatory update. It's a structural redesign of Medicaid eligibility that will affect hundreds of thousands of Pennsylvanians and reshape how hospitals, long term care providers, and state agencies operate. And unless we prepare carefully, the people most at risk are those who are too sick to work and too sick to navigate the documentation required to prove it. On June 1st, 2026, CMS issued an interim final rule establishing a nationwide 80-hour per week or per month work or community engagement requirement for most Medicaid expansion adults aged 19 to 64. Enforcement begins in January 1st, 2027. The rule also narrows the definition of medically frail status. A diagnosis alone no longer qualifies someone for exemption. Instead, individuals must demonstrate that their condition significantly impairs their ability to meet the 80-hour requirement. Beginning in 2028, states must require clinicians to clinician documentation or claims evidence at regular intervals. This is the first time CMS has required every state to build a work verification infrastructure. It is not optional. It is not a pilot. It's a national mandate. Impacts on medically vulnerable Pennsylvanians. In my health system, the individuals most likely to be affected are those avoiding work. They are patients in active chemotherapy, adults with severe mental illness, individuals recovering from strokes or traumatic injuries, people with long COVID, or autoimmune disorders. Caregivers whose responsibility fluctuate week to week. A functional impairment is difficult to document on a schedule. Cancer fatigue does not follow a reporting cycle. Neither do bipolar episodes, lupus flares, or cognitive effects of long COVID. Yet the rule requires individuals to repeatedly prove functional limitations in 6-month intervals. Administrative barriers will drive coverage loss. Evidence from prior state demonstrations show that most disenrollment occurs because people cannot complete paperwork, not because they are ineligible. In Arkansas, 18,000 people lost coverage in the first months of implementation, largely due to reporting failures. Coverage gaps disrupt treatment and increase downstream costs. When Medicaid lapses, chemotherapy is delayed, insulin is rationed, and mental health medications are interrupted. These gaps lead to avoidable hospitalizations, emergency department visits, and long-term institutional care costs. Ultimately fail on the state and on the health systems like mine. Operational and fiscal implications for Pennsylvania. A state administrative capacity to comply with federal rule. Pennsylvania Department of Human Services must build a statewide network verification portal, create medically frail assessment protocols, train county assistance offices, manage appeals and good cause for exemptions, integrate data across workforce, education, and Medicaid systems. This comes at a time when DHS is still recovering from the Medicaid unwinding and facing workforce shortages of its own. Impacts on hospitals and health systems. Coverage instability effects. Hospital thought put. Patients cannot be safely discharged to home and community-based services if their Medicaid status is uncertain. Behavioral health continuity, gaps in medication coverage, destabilize patients, and increase crisis units utilization. Long-term care transitions. Nursing facilities cannot admit residents without confirmed payer sources. Uncompensated care. Rural hospitals already operating on thin margins will absorb the cost of interrupted coverage. Fiscal risk to the Commonwealth. While CMS suggests potential savings from reduced enrollment, the evidence from prior documentation shows increased accumulated current related administrative costs, higher uncompensated care burdens, greater long-term Medicaid spending due to worsened health outcomes. In short, the rule may reduce enrollment on paper while increasing costs in practice. Policy options for the Pennsylvania Senate. Even within federal constraints, the Commonwealth has meaningful levers to protect medically vulnerable residents. Strengthen the medically frail pathway. Adopt clear, inclusive, functional impairment criteria. Accept multiple forms of documentation, including treatment schedules and claims history. Extend exemption periods for stable chronic conditions. Partner with health systems to streamline verification. Reduce procedural barriers. Simplify reporting portals. Provide multilingual, plain language instructions. Implement grace periods for late documentation. Auto-exempt individuals with high acuity claims patterns. Protect community continuity of care. Establish robust good cause exemptions. Ensure rapid reinstatement for individuals who cure procedural defects. Coordinate with providers to prevent treatment disruptions, treatment interruptions. Monitor and publicity report outcomes, track enrollment reasons, or track disenrollment reasons, report medically frail document determinations, and appeal outcomes. evaluate impacts on employment, health, outcomes, and state costs. These, these steps will not eliminate the, the challenges created by federal rule, but they can significantly reduce harm. Conclusion: Medicaid work requirements represent a profound shift in the structure and purpose of the program. For medically vulnerable Pennsylvanians, the risk is not that they will refuse to work, it is that they will lose coverage because they are too sick to complete the paperwork required to prove they are too sick to work. As a healthcare system leader, I see the human consequences of coverage instability every day. As policymakers, you have the opportunity to ensure that Pennsylvania implements the federal mandate in a way that protects continuity of care, minimizes administrative churn, and upholds the dignity and health of the people we serve. Thank you for your attention and your commitment to the health of our Commonwealth. Okay, guys, I'll be back on with B shortly. Give me a bit for that, please. And I will see you guys shortly for B. For now, Gator Wellness, take care, folks.